This eHIV review program is presented by DKB Med Radio.
Training HIV care providers to both screen and prescribe or connect patients with medications for opioid use disorder really can break down barriers to access of these life-saving medications and ensure that our patients are receiving integrated, comprehensive care.
People living with HIV and substance use disorder, a clinical perspective. Welcome to eHIV Review. Tobacco, alcohol, stimulants, opioids. Substance use disorders. They're prevalent among people living with HIV. They diminish ART adherence, increase the risk of non-HIV related comorbidities, harm both an individual's physical and mental health. How can clinicians recognize a substance use disorder in their patients? How can they differentiate an SUD from intermittent substance use? How should they treat it? What does the evidence and the expert advice say? To discuss these issues, we're joined today by Dr. Ayesha Appa. She's an assistant professor of medicine at the University of California, San Francisco, and a clinician and researcher specializing in HIV, infectious diseases, and addiction medicine. For our guest disclosures and additional CME information, please go to our website, ehivreview.org, and select the Volume 9, Issue 10 link. I'm Bob Busker, executive producer of DKP Med's e-literature review video programs. Dr. Appa, thank you for joining us today.
Thank you for having me. I'm really, really excited to be here and glad you're featuring this topic.
Our overall learning objective for today's program is to describe strategies to improve identification and management of substance use in people living with HIV. The focus of the first part of this conversation is on describing the diagnostic tools and tactics for differentiating whether a patient's substance use should be considered hazardous intermittent use or as evidence of a substance use disorder that needs addressing in the HIV care setting. So that said, if you would please, Dr. Appa, start us out in the clinic with a patient scenario.
Happy to. So let's take a case of Samantha. She's a 47-year-old woman who's been living with HIV since 1999 and is currently experiencing homelessness. Her HIV has been intermittently controlled over the years, generally when she has access to stable housing or is staying with her sisters. And she's currently prescribed a combination pill, abacavir, lamivudine, and dolutegravir, though she has not taken her antiretroviral therapy, or ART, in the past 3 months. And her CD4 count is 225 with an HIV viral load of 24,000 copies. You're meeting her for the first time in clinic, and while reviewing her chart, you notice multiple ED visits for intoxication, a history of injection drug use, and recent urine tests that are positive for methamphetamine, cocaine, and fentanyl.
So, 2 points about this patient. One is that she's someone with a history of intermittent HIV control. And 2, although her chart shows some substance use, so far there's no clear evidence to diagnose a substance use disorder. How would you advise a clinician to approach this situation in practice?
Yeah, it's a great question, Bob, and I love that you highlighted those two key features of this case. I think first, it's really important to open the dialogue about substance use in a non-judgmental and supportive way, which includes asking permission to discuss substance use. Ultimately, substance use disorders are a clinical diagnosis that providers get to by understanding how substances have affected someone's life. So you might be gleaning information from the chart review that we've sort of gone over in what we know about Samantha, but starting that conversation with the patient is key. After you've asked permission to discuss substance use, something simple like, is it all right if we talk a little bit about drugs and alcohol? And a validating screening tool, such as the National Institute on Drug Abuse, or NIDA's single question screening for drug use, is a great place to start. So that is, again, another simple question. How many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? And that allows for, it's not a yes or no question. It's sort of an assumption that it may have happened, which can really put someone at ease and open a conversation. And I'll say that uh, something that is just, while this is a extensively evidence-based tool that's been used in multiple different settings, um, providers, you'll make it your own. I think once you incorporate this into your practice, I think having the words or doing this often allows a level of comfort that I also want to affirm providers in sort of creating a script that feels good to you. I'll say that there are a number of really phenomenal tools out there to more clearly define hazardous substance use. Um, but after that screening tool, what I end up doing is having a conversation with my patient that allows for assessment of the DSM-5 criteria, which many may be familiar with, but is how all substance use disorders are definitively diagnosed. And again, the DSM-5 criteria, it's a number of criteria that are easy to look up and remind yourself of, but essentially is all about understanding, has this substance had an impact on your patient's health and well-being, on their social life and sort of ability to function as they'd like to in the world, and has it led to physical dependence or withdrawal? All that said, I'd say that using both a screening tool, keeping the DSM-5 criteria in mind while sort of further exploring how a particular substance has impacted your patient's life, whether related to HIV or not, can really help differentiate between intermittent substance use and a substance use disorder that requires treatment. So, and that's really key in tailoring interventions that you want to incorporate into your HIV care setting.
Good overview, Doctor. Now, how do we apply it to Samantha's case?
Great question. So, what Samantha shares with you is that she has struggled with both cocaine use and methamphetamine use for decades. She started using stimulants to maintain vigilance when she was sleeping on the street at night. As we know, she's experiencing homelessness and has really struggled to stop using those substances, both of which have gotten in the way of her ART adherence.
What about the fentanyl?
She tells you that she does not intentionally use fentanyl. We know that the fentanyl was found in her urine drug test, but she wonders whether it was in a friend's pipe that she might have used. And what that allows us to do as clinicians is identify the methamphetamine and cocaine or stimulants as the use disorder that we need to focus on, as we know that has led to quite a bit of life disruption. Whereas the fentanyl or the opioid that was in her urine testing is unlikely to be a substance use disorder or an opioid use disorder that will need treatment in this case. So, what we can now do is turn to how we can offer treatment for stimulant use disorder, which is the likely thing contributing to her HIV treatment non-adherence, as she's told you, as well as harm reduction strategies that prevent her from being exposed to fentanyl again.
I don't think anyone would argue that Samantha's stimulant use disorder and her poor ART adherence both need to be addressed, especially since both are impacting her overall health. My question is, how do you do it? How do you balance those needs?
Yeah, it's a great question, Bob, and I think that it's so important to take a holistic approach, as I think more and more providers these days are recognizing that substance use may be driving poor ART adherence. So really the two topics are hand in hand. One of the first steps that clinicians can take is really identifying potential root causes of her substance use, and seeing if there's anything to intervene upon there. And then next, as we've done with Samantha, I think categorizing the severity of her substance use and determining whether it's intermittent substance use or a substance use disorder that needs treatment is crucial, as it'll help us prioritize the specific management that's indicated, as different substance use disorders have different first line treatments. The next consideration is how best to modify someone's HIV treatment or their ART to support your patient who is still using substances or is working on cutting down, which might take some time. So an example of this is if Samantha is telling you, I have interest in reducing my methamphetamine use, but I'm worried I may not be able to make that change immediately. And I'm worried I might not be able to take my abacavir, lamivudine, and dolutegravir every single day. Might it be prudent to switch her to a regimen for a different single pill, like tenofovir alafenamide, emtricitabine, and Kobe-boosted darunavir that is less likely to lead to HIV virologic failure with resistance in the face of intermittent adherence?
Once the substance use disorder is identified, how would you integrate its management with HIV care? What would you do in Samantha's case?
That's great. So we've confirmed that Samantha has a stimulant use disorder. So HIV care represents a key opportunity to engage her in evidence-based treatment that we have. Engaging a patient with stimulant use disorder in evidence-based treatment involves both behavioral strategies as well as a discussion about medications. First line treatment for stimulant use disorder is a behavioral intervention called contingency management. That is an incentive based treatment, often delivered over 12 to 24 weeks to help patients meet their goal of reducing or abstaining from stimulants. And then oral medications might include mirtazapine, intramuscular naltrexone with oral bupropion. And I'll say that there are no FDA approved medications for stimulant use disorder, but those two medication strategies are the ones with the highest degree of evidence behind them. And then also key is management of complications of stimulant use disorder, like heart failure, hypertension, pulmonary hypertension, or psychosis. We also know that other behavioral treatments like cognitive behavioral therapy, or for some patients, residential treatment might be helpful as well. I think another really key aspect of care that I see in clinic all of the time is that addressing barriers like stigma or discrimination that patients like Samantha might be facing as they enter HIV care settings is really key to ensure continuity of care across these domains and enhance treatment retention, both in with regards to HIV and her stimulant use disorder care.
Contingency management. How accessible is that, and how can HIV providers locate these kinds of services?
Great question. Contingency management has decades of research supporting it and hundreds of randomized controlled trials finding efficacy, but implementation has been really quite limited over the past number of years. There has been some movement in recent years with contingency management available within the VA system, and some states like California, Washington, are offering pilots of public insurance funded contingency management. That said, it is implementation is still limited. So when it comes to finding how can HIV providers locate these services, I think really the answer here is integrating and partnering with addiction medicine or addiction psychiatry to either help locate or develop contingency management programs in or adjacent to HIV care. I think using that multidisciplinary team that includes addiction specialists and case managers and others who can support the patient through this process is really key to optimize both ART adherence and stimulant use disorder treatment.
The idea of HIV care providers working in tandem with addiction services. That's a need we've heard from both our expert guest authors like yourself, as well as from the patients who shared their journeys through HIV and addiction through our Patient Voices programs.
I'm so glad you've heard this from both providers and patients. In the last few decades, I think we've come a long way and really come to understand addiction as a chronic disease rather than a criminal, legal, or moral problem. So it really makes a lot of common sense that to deliver truly patient-centered care, we need to offer HIV providers and patients tools to manage addiction in the HIV primary care context, just like we'd expect HIV primary care providers are managing chronic diseases like hypertension, diabetes, or major depression.
Nicely said. Thank you, Doctor. Our key learning focus for this part of our discussion is to describe the diagnostic tools and tactics for differentiating whether a patient's substance use should be considered hazardous intermittent use or is evidence of a substance use disorder that needs addressing in the HIV care setting. What are the most important concepts you'd want our learners to take away from our conversation?
The tools and key takeaways for diagnosing substance use disorders that we talked about include one, starting with a non-judgmental dialogue, creating a warm, welcoming space, and to honestly discuss substance use goes so far in really advancing care for substance use disorders in the HIV setting. Two, use validating screening tools like NIDA's single question screen for drug use to help understand whether someone has intermittent substance use or a possible substance use disorder. If positive, use the DSM-5 criteria to help diagnose substance use disorders. And if a substance use disorder is identified, it's important to tailor interventions based on the substance use disorder identified, optimally integrating addiction treatment into the HIV care plan. And finally, holistic care coordination. Ideally, we are able to collaborate with multidisciplinary teams, including addiction specialists and case managers, to discuss and address both HIV adherence and substance use in a really comprehensive manner. Hopefully, by implementing these 4 steps, clinicians can better address the intersection of substance use and HIV care, ultimately improving outcomes overall.
Nice summation, Doctor. And we'll return with Dr. Ayesha Appa from UCSF in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's eHIV review program, focused on strategies to improve identification and management of substance use disorder in people living with HIV. We've been speaking with Dr. Ayesha Appa, an infectious disease and addiction specialist from the University of California, San Francisco, about the need for HIV care providers to determine whether a patient's substance use is hazardous but intermittent or is evidence of a substance use disorder. Let's turn now to the second focus of today's program, explaining the benefits and risks of methadone and buprenorphine as medications for opioid use disorder in people living with HIV. So if you would please, Dr. Appa, take us back to the clinic with another patient scenario.
Happy to. So our next case is a 38-year-old man with a history of injection fentanyl use and HIV for the past 5 years. He's on ART, but has struggled with adherence due to severe opioid use disorder. And after a recent opioid overdose, he recently expressed interest in starting a medication for opioid use disorder.
Now, you noted he's been struggling with adherence due to severe opioid use disorder. Talk to us about the mechanics of OUD. What do we need to know about how opioid use disorder affects adherence?
Yeah, it's a great question. Like our prior case, Obviously, every patient's journey is different, but on the whole, opioid use disorder is well known to disrupt ART adherence, as living with opioid use disorder often involves the person experiencing opioid withdrawal, which can compromise a person's ability to maintain access to or take a daily medication, ultimately increasing viral loads and the risk of HIV transmission, particularly if there's injection drug use involved. I think something to make our clinicians understand this or sort of empathize with this a bit more is that opioid withdrawal can feel like simultaneous anxiety, flu, um, and full body pain. And really, if you have to prioritize finding an opioid, say fentanyl, to feel just able to exist on a day-to-day basis, it's hard to imagine how you'd also be able to prioritize ART adherence, behind food, shelter, et cetera. The other important thing to note is that opioid use disorder also compounds the risk for comorbid conditions like hepatitis C, liver disease, and opioid overdose, really further complicating care of people living with HIV with opioid use disorder.
So, doctor, for people living with HIV, what are the most effective treatments for opioid use disorder?
We have two incredibly effective medications for opioid use disorder. Methadone and buprenorphine are just essential tools and have been found to significantly reduce mortality, 50% reduction in all-cause mortality associated with the use of both of those medications. It's important to understand that these are different medications with different side effects and different subjective experiences. So let me share a little bit about this. Methadone, like fentanyl, is a full agonist opioid that may have other effects. Methadone can have serotonergic properties, antagonizes the NMDA receptor, and patients may report feeling like feels like a warm blanket and may be somewhat sedating. Buprenorphine, on the other hand, is a partial opioid agonist and overall can feel somewhat activating as compared to other full agonist opioids. And some patients may really enjoy and appreciate that effect, and others may find that off-putting or less desired. Overall, it's really important to just discuss what patients' experiences might have been and what their preferences are moving forward to help them select the best option for them. And sometimes that may mean trials of either or both medications to really figure out what will work for them in the long term.
Are there concerns about drug-drug interactions with OUD treatments for people on ART?
With regards to drug-drug interactions with ART, honestly, in the contemporary era, there are relatively few, but I will say that NNRTI medications such as efavirenz can decrease methadone and buprenorphine concentrations, but we'll note that doravirine does not have that interaction. And protease inhibitors can either increase or decrease concentrations of methadone and buprenorphine to a smaller degree, really depending on the pharmacologic booster. So it's always important to work with your HIV pharmacist to address specific drug interactions. I will say that I have a number of patients on, say, COBI boosted darunavir or ritonavir and darunavir that are also on methadone or buprenorphine, and it has never been a contraindication, but something that we may pay attention to if changing doses.
These treatments for opioid use disorder, how should they be integrated into the clinician's overall plan for HIV care?
Such an important question. So buprenorphine in particular can really be well integrated to HIV primary care and prescribed by anyone with a DEA license. In the last year, the X waiver that some clinicians may be familiar with, that required 8 hours of training and a particular application via the DEA to be able to prescribe buprenorphine for opioid use disorder is no longer required. So while it is important to understand and feel comfortable prescribing buprenorphine for opioid use disorder, and again, that's where that multidisciplinary support from addiction specialists in the clinic or related to the clinic will really come in handy. HIV care providers, anyone with a DEA license can prescribe buprenorphine for opioid use disorder and should. Methadone, on the other hand, has different federal regulations and cannot be prescribed outside of opiate treatment programs, which are federally regulated. This can limit access, but I'll say in recognition that this difference in regulations between the two medications are really creating unnecessary barriers for this life-saving medication. These regulations will likely change in coming years. There's quite a bit of sort of congressional legislation that is being actively considered at the current time. Another medication that we haven't talked a lot about is intramuscular naltrexone, which is also FDA approved for opioid use disorder. Naltrexone is an opioid antagonist or blocker, and while it is another efficacious option, its rates of retention are quite a bit lower than methadone or buprenorphine, so it is often not a go-to in clinical practice. Integrating medications for opioid use disorder, particularly buprenorphine, as I've discussed, is really critical to improving outcomes. And co-located services can really make it easier for patients to access both HIV care and addiction treatment simultaneously.
Co-locating diagnosis and treatment services will likely improve outcomes for many individuals with OUD. But what about strategies designed for marginalized populations? What can you tell us about those?
That really is the question, right? It's, I think there are a few things that come to mind. Expanding access to medications for opioid use disorder in rural or underserved areas through telemedicine or mobile health units could help reach populations that lack local resources. Also key is policy advocacy to relax regulations around methadone access, as well as funding to support more HIV providers to prescribe buprenorphine. Training HIV care providers to both screen and prescribe or connect patients with medications for opioid use disorder really can break down barriers to access of these life-saving medications and ensure that our patients are receiving integrated, comprehensive care.
Thank you, Dr. Appa, for this very interesting discussion. The learning focus for this part of our program is to explain the benefits and risks of methadone and buprenorphine as medications for opioid use disorder in people living with HIV. What are the key things you'd want our listeners to take back to their practices?
A few key points related to this case. One, screen for opioid use disorder routinely in HIV care. Identifying opioid use disorder is critical to improve HIV outcomes that we discussed. And because of how efficacious our medications for opioid use disorder, methadone and buprenorphine are, the reduction in all-cause mortality is really important for our patients. Untreated opioid use can disrupt ART adherence and increase transmission risk, in addition to putting patients living with HIV with opioid use disorder at risk for opioid overdose death. Two, incorporate evidence-based treatment like methadone or buprenorphine into your patient's care plans. As we've just said, these medications significantly reduce mortality and improve retention and care, and so should be a standard part of HIV management for patients living with HIV and opioid use disorder. Three, prioritize integrated multidisciplinary care. As has been a thread throughout this whole conversation, HIV care providers should really collaborate with addiction specialists to deliver comprehensive care, ensuring that medications for opioid use disorder and antiretroviral therapy are managed in tandem to optimize outcomes. Four, addressing barriers to access, particularly for marginalized populations, is key. Many patients face logistical and systemic challenges in accessing either methadone or buprenorphine, and expanding access through telemedicine, mobile clinics, or policy reforms, whether local or national, is really essential for reaching underserved communities. And finally, five, tailor treatment plans to individual patient needs. Personalizing the approach, considering the patient's readiness for treatment, addressing any stigma or discrimination that they've experienced, as well as hesitance, and supporting long term care engagement. Really, just letting your patient know that you're with them on this journey will maximize the effectiveness of medications for opioid use disorder in the HIV care setting.
From the University of California, San Francisco, Dr. Ayesha Appa, thank you for sharing your knowledge and expertise with us in today's eHIV review program.
My complete pleasure. Thank you so much for the opportunity. And I really hope that everyone has learned a thing or two.
For eHIV Review, I'm Bob Busker.